All right, everyone, we are going to get started with our panel discussion around strategies to reduce hospitalization. My name is Jodi Nerell. I am a Director in External Affairs and Community Health for Sutter Health, representing both an individual with lived experience with the psychiatric system in California, as well as a professional that's been working in the system for, unfortunately, many decades now. I'm too old to admit, but I want to thank the Steinberg Institute for the invitation here to moderate this panel that many of our panelists here have committed their careers to serving our community members with mental health and addiction care struggles and creating a continuum of care and an ecosystem that serves members in their communities and not only works to prevent hospitalizations, but also in their care environments, reducing the need to return to hospitals once they were seen in acute care settings. So I won't read the entire biographies of all four of the panelists here, but please take a minute to review them and their work. But I will introduce folks here, and then we'll kick it off with Arvind going through his personal experience. But let me introduce to you Liz Basnett is California Emergency Medical Services Director. Dr. Amiee Moulin is Behavioral Health Director, Emergency Medicine Doc for UC Davis. Arvind Sookanan with the Technical Assistance Center and Fountain House, and Dr. Jonathan Porteus, who is the CEO of WellSpace Health. So I am going to just set the stage here with these folks and let them take us through the next hour, really elucidating their vision and their work in operationalizing some of the very sort of high-level policies that were covered earlier, and how in their own institutions and spheres of influence have been able to create local and regional and statewide communities of care to serve our population that we're all here to discuss today. So Arvind, if you would be so willing to kick us off, sharing your personal experience with hospitalization and how that sort of has driven you in your role right now with TAC and Fountain House.
First off, I just want to say I'm incredibly grateful and deeply honored to be able to be here. Came all the way from New York and to talk about a topic that's really meant a lot to me, has really impacted my life, and I'm really, really grateful to all of you for listening. I've been burnt more times by bad crisis response and unnecessarily hospitalization than, in some ways, more than my own illness. More often than not, I just needed someone to listen to me. Someone that could understand I'm a human being too, and that I was more than my illness, even if I was symptomatic. I had been hospitalized countless times, throughout New York State, but as well as DC and Florida. I've had really bad interactions, with police, as well as with mental health professionals that just didn't quite understand, what I was going through. That I was more than my illness. That I was more than just a patient, just a number, just a client. That I was a human being. That there was a lot more to my crisis than just my symptoms. One of the most difficult experiences in my life was, in my first college experience in Florida. I was completely alone. I'm a first-generation college student, and I did not have any friends on campus. I didn't know anyone that went to that school, and I was incredibly alone. But I was okay. It was in my first 2 months. But I started to hear voices again. I was struggling, a bit, but I was okay. I was still able to go to class, do my work. And what was so difficult, though, is, again, I was incredibly alone. And I thought the logical thing to do, because I didn't know anybody else, was to go to the college counselor's office. Speak to a mental health counselor, and then go back to class just like everybody else. I wasn't a threat to myself. It wasn't a threat to anyone else. And after just 5 minutes of talking to the mental health counselor on campus, they said, wait outside. Next thing you know, police show up. And I get put in handcuffs, put in the back of a police cruiser. Mind you, I'm incredibly calm. I am cooperating because I know how this has gone before for me. But I reiterate, I just want to talk to somebody and go back to class. And I'm held against my will for 72 hours at the hospital. I'm still calm. I still try to, go through the system because I know, again, how this works. Just so I could prove that I'm going to be okay. I just want to return to class. Next thing you know, the dean of students at the college calls me at the hospital and says, I have 2 days to remove my stuff from campus. And as a first-generation college student, as someone that just wanted to be like everybody else, every other kid my age at that time, I wasn't afforded that. And when I got back to New York, believe it or not, I was in crisis because why? I was back to square one. Fast forward, I still have mental health challenges. I have schizoaffective disorder, full disclosure. And a less remarkable story. Just a couple months ago, I was not in a good place. And sorry to call him out, but my friend Ken Zimmerman at Fountain House, I gave him a call. And usually, as a New Yorker, when you talk to a guy from New Jersey, you get more depressed. Just saying. But it was that one call that was so transformative. It was not with a clinician. He's a lawyer, for Christ's sake. But it made the world of a difference because he was a friend. He was just someone that I could talk to, that I knew that I could just return. And afterwards, I was able to return to going back to work, doing my thing, and living life. So much of hospitalization has focused on trying to treat your symptoms, but the reality is, in my work at TACT and doing this work across the country to transform crisis systems, I've seen people just like me who also want to be seen as people. And if we can do that, we're headed in the right direction in terms of transforming the crisis system.
Thank you so much, Arvind. Can you possibly think about through your work with Fountain House, what would be some of your top priorities to help disrupt this pipeline that we have created from crisis to involuntary holds to ERs, and then rinse and repeat without much acknowledgement of the impact and re-victimization and traumatization that is layered upon individuals that find themselves swept away in that pipeline.
Well, the clubhouse really transformed my life. Ever since I became a member in 2018, I had been hospitalized close to over 20 times in the years prior, and since joining Fountain House in 2018, I've been only hospitalized, I think, about 2 or 3 times. In the past few years, I've been able to graduate college, get a full-time job, thanks to this community system of care that now anytime that I am symptomatic, I have a whole network of people that are gonna catch me when I fall. And in the way that I need them to. That's what's remarkable. It's about providing this person-centered, holistic crisis response that is so critical, And on top of that, it's the relationships that matter. I just mentioned, this back and forth that I have with Ken, how helpful and therapeutic that is, but also with other people with lived experience, members of the clubhouse that have helped me in my own journey. And I've been able to help them by making it human, not, making it seem as a person that just needs to go to the hospital because they're symptomatic, because they're struggling with their voices or something like that. By focusing on what really matters to them, such as do they have community? Do they have a stable home, a place of their own to call home? Those are the things that matter. They're not, incredible, innovative ideas. They're really basic human needs that are so meaningful, especially, again, the relationships. It doesn't cost anything.
Thank you. All right, so Liz, you're in
Yes.
the batter's circle. Okay. So one of the reasons ERs have become sort of this de facto treatment location for individuals is sort of the structural elements that we have up, around, related to ambulances and triage to alternate destinations. Can you sort of frame this up for us, for those of us that are just kind of getting familiar with that? That was that was something that until I had joined Sutter, I wasn't aware, and we had taken on. I wasn't aware of the constraints in ambulances and some of the other things that were sort of, definitely, spokes in this hub that are all sort of contributing to how we ended up where we are today. So can you help us get a handle on this and where this opportunities exist to improve the system?
Yes, absolutely, and thank you for having me here today. So I think just to this point, right, of getting folks the right care at the right time in the right way with the right resources, just to give a little bit of scope and magnitude on the EMS system, right, we do 7 million plus transports a year, and when a paramedic or an EMT goes out into the field, they have to fill out an electronic patient care record, right, and on that patient care record says primary impression. What is the primary impression of the EMS professional? And just for your context, that primary impression in all of our counties statewide, top 5 is behavioral health. In half of our counties, it's top 3. And this equates to well over 1,000 patient care touches a day by EMS professional, 1,000 opportunities a day here in California where somebody has a primary impression of behavioral health. So just giving that scope and magnitude for today. So the program kind of, and it certainly has evolved in the last 10 years, but essentially the way traditional EMS services have worked across the nation is that somebody calls 911. If they meet a certain set of clinical criteria, et cetera, they're transported to a hospital. It's the only legal pathway that someone could be taken. You either sign out against medical advice, AMA, or you go to the hospital. There's no other pathway. And so, through legislation, we have expanded those destinations, right? Mental health facility or a sobering center. Recognizing that's only 2, right? There's a lot of transformation and more things to be done. And just to recognize that's EMS only accounts for 15% of the traffic that walks through an ED hospital. So I do want to say, yes, we have these 1,000 opportunities a day, and we have a program where counties can apply to have infrastructure within their community be certified as alternate destinations, and their professional workforce can be trained. And instead of folks, if they meet a certain set of clinical criteria, instead of folks going to an emergency department where they may not be served by the right folks in the right way at the right time, whatever it is, maybe that ED is very busy, this allows this alternate destination to really meet the folks where they are and get them the resources they need.
Great, thank you. I'm going to bounce around a little bit if this is okay, because Jonathan, as I understand it, WellSpace is one of those alternate destination sites. Can you walk us through what that looks like, what opportunities that presents for our community members?
Yeah, thank you. Just to level set, Jonathan Porteus, psychologist. Long before I became a psychologist, when I was 19, I hospitalized my brother, big brother, in the hospital where he was a med student. And he's never recovered from his schizophrenia. And a couple of years before that, when I was 17, I was staying in a kind of remote place with a friend and walked into the garage and found her sister hanging there. And there was no one else there. And about an hour later, the ambulance came, but I'd already cut her down and tried to revive her. But, so it kind of digs deep, and, I've had other life events. But my goal has been to try and re-engineer and build the appropriate crisis response system, among other things that I've done. And part of that, I think Senator Bauer-Kahn mentioned, there's a person to call, a person to respond, and a place to go. My organization runs 988 for 32 out of 58 counties, and so we are the place to call for 988. But the person to respond is mobile crisis. The place to go is crisis receiving. So some years ago, with the help of then Mayor Steinberg, we actually opened a crisis receiving site in downtown Sacramento as a pilot, as a way of showing what crisis receiving would look like. 3 years, we had 12,000 visits. Last year, we had 4,000 visits. 10% of the people who came in, intoxicated, psychotic, often both, went straight to treatment. People who never had been in treatment, people who never thought of treatment, went straight to treatment. Hospitals, law enforcement, our main partner. But we've been working diligently with LAMSAs and with the state to become a certified triage alternative destination. And now we have this sort of distinct delight of being that organization that you can drop people off 24/7. We're building our second site on a campus in South Sacramento.
Liz, can you share with us some of the barriers that are present right now that you and many others are trying to work through in order to scale your work?
Yes, I think there's, a couple barriers. I think just to say it how it is, maybe in front of this group of trusted peers, I think we still have more work to do on the statutory side and on the regulation side. I don't think that's a secret to anyone here. I think, as everyone has said, it's looking at the whole continuum of care and where are these other alternate destinations, and even outside of triage alternate destination with, another program, community paramedicine. How do you meet people in their home that maybe just need post-hospital discharge follow-up and they can't get that and they maybe sink into a depression or other things? Maybe it's not even an alternate destination. Maybe it's meeting people where they are. But, we have to design a system with the partners in this room and with the legislature that really embodies that core value. And then I think, outside of that is just making sure there is the infrastructure, both not only in people, and we've heard about the shortages, but also in places when we do want to have these alternate destinations. How do we, make sure that infrastructure exists and we don't build something where there's no infrastructure necessarily to support it? And then, like you started, right? Training and education and public awareness. If folks don't know this exists, they can't put in the application, they can't do this great work, they can't do all of these things. And so really, even just being here today, getting that information out there, getting that knowledge out there. But I think if we can overcome those three barriers, I think that's the key to really expanding into the healthcare continuum, seeing EMS as healthcare, not necessarily public safety, and making sure we take advantage of those 1,000 touches every single day happening right now while I'm sitting here talking. I think that is the metric of success to move past those barriers.
Thank you. Dr. Moulin, for someone that finds themselves in a crisis and in an emergency department, can you share about the Bridge program and everything around that?
Thank you. I'm Amiee Moulin. I'm an emergency physician and addiction medicine physician, and one of our programs that we've invested in the state of California is bringing addiction treatment into our emergency departments. So the state of California has invested in training our emergency physicians to recognize opioid use disorder, start medications, but really most importantly, and I think that's really important for this piece, is bringing folks with lived experience into the emergency departments is really been, I think, the radical innovation of Bridge, is bringing in folks who have that lived experience. We call them substance use navigators, behavioral health navigators, and now, for billing purposes, community health workers. But having that person there who can connect with that individual and help kind of navigate the extremely fragmented county managed Medi-Cal plan system from the emergency department to a outpatient appointment. And by including both medications on demand in the ED and that human with lived experience, over half of the people we identify with opioid use disorder get started on medications. 1/3 of the people, 1 in 3, goes to a follow-up appointment, and 1 in 9, and these are people in the ED, are still in treatment at 6 months. And so we've seen that this can be a huge opportunity to be that open door. Like there's a lot of bad things about emergency departments, but we are open 24/7. No shoes, no shirt, you come in however state you are, we are there. And we are open at 2 a.m. on a Sunday. And so having that space where someone can walk in and say, hey, today's the day that I want to start my journey towards treatment, we're open. And I want to say one other thing about this, listening to you and listening to our previous panel, that I don't want us to forget in this conversation around hospitalization and crisis services, is that the thing that, when I talk to people who are particularly experiencing a mental health crisis, the thing they wanted is no destination. They wanted their psychiatrist to call them back last week, right? Like they didn't want to have the crisis, they didn't want to have the intervention, they didn't want to have any destination. They wanted to stay in their home, and they wanted someone to return that phone call last week and prevent all of that. So just wanted to say, we need to have more options, but really the best intervention is someone who returned that phone call yesterday.
Thank you, Dr. Moulin. For those of you that don't know, Dr. Moulin and the Bridge program had nearly 300 hospitals participating in the Bridge program. Sutter Health was one of those that benefited greatly under Dr. Moulin and Cal Bridge. We've got 23 substance use navigators in our health system, and bringing individuals in the ED with lived experience, meeting individuals where they're at, following up with them, addressing the barriers to their engagement and care post-discharge, really does hit what, to Arvind's point and many others' point about needing folks there to listen, to hold space with you, not a destination, not necessarily always a pill, not always somebody holding space in the darkness. That makes all the difference in the world. And our substance use navigators, which are now formally Sutter Health employees, we were finally able to do that after 3.5 years of grant funding. It's a huge, huge win for the health systems to be able to recognize and understand the incredible value that one's lived journey brings to the journey of another person who's on a similar point on that path. Much gratitude to you, Doctor. You're just continually holding that torch and, always looking for excellence and how do we do the next best thing in this space. So I wanted to thank you for that. And by virtue of all that work, we were allowed to connect with many county partners and community clinics. There's FQHCs. I think Communicare Olay is in the room. We were able to contract and work with our community clinics to ensure that individuals that are stepping down from our acute care settings at the time of their worst need are able to get back to their primary health homes and be able to be served in that community-based level of care and not, have to find themselves back on our end. So thank you for that. So big question I'll start with you, Dr. Moulin, but then extend it to the group. ideal crisis response system. What would that look like if you were the architects? And I'll let you take that one.
If I was the architect, it would look a lot like a crisis system where someone comes to your home, like we have a lot of our mobile crisis, but that needs to be available 24/7, right? Because crises are not a Monday through Friday 9 to 5 adventure. As I know from an emergency department, you need to have that 24/7 availability where someone can come in and help connect that person back to who their support network and their care provider. Because there's the crisis intervention, but really it needs to be connected, right? It needs to be not just that intervention now, but who is the person who feels connected to that individual who's experiencing the crisis. And I think a lot of this is, some of these programs that we hear about is that person in crisis, they don't need just something in that moment, but that needs to be better coordinated in that ongoing way. Incorporating the voices of people with lived experience and highlighting them, I think, is really critical in our work in emergency departments. It's just been transformative in the way that we're able to engage with folks and the way that staff interact with people. Just having that person with lived experience to model the communication strategies, I think, has really been transformative. So would incorporate this dream of coordinated care, timely, and elevating the voices of people with lived experience.
For me, the ideal crisis system includes more voluntary entries to getting care. It includes empath centers, but also, as I mentioned before, clubhouses. And having that wraparound service, having all the people that are in your care network that you choose, the people that you trust to know what to do when you're in crisis. And that's a combination of family, friends, your psychiatrist, but your therapist, whoever you might want that has your best interest at heart, that knows what you need and you want, and helping you define what your crisis is. I think the problem that we have in various crisis systems across the country is that you have so many different agencies defining what crisis is for the person living through the crisis. And it's really unfortunate because more often than not, it's the person that is going through the crisis that knows what they need, that knows what they want, that knows the real pathway to getting out of the crisis. And then post-hospitalization, post-crisis care is so critically important. Instead of just having referrals, there should be consistent follow-up. There should be, a requirement that a lot of these major facilities, are held accountable for ensuring that people actually have access to the services that they were promised. That's a big part of it. What good is a phone number to me when I'm leaving the hospital? I don't have a home. I don't have people to depend on, how am I in recovery at that point? I would end up right back in the hospital. So I think, in short, there should be more voluntary options, and there should be accountability across the system, and a codified definition of crisis.
I just want to say one other thing about this, which I forgot to mention, is we talk about reducing hospitalization for mental illness, but on the substance use side, there are no real inpatient medical detox in the state of California, right? There are 11 chemical dependency and recovery hospitals for the entire state of California, and 0 who take Medi-Cal. So, we, on both sides, right, we need to have more options, more voluntary options for both of these sides. But for our folks who have addiction treatment, we kind of backdoor it through our sobering centers, and hopefully there's no one from my institution here. We do like this ED observation, underground, 48-hour kind of inpatient detox that is unfunded by Medi-Cal because they don't pay for observations, so hopefully no one will rat me out. But there's no options. And so that's another piece that we have to think about. There's nothing.
Just again to level set, 988, just in terms of building a system, 988, you can only be a 988 crisis center if you're nationally certified by the American Association of Suicidology. So that piece is actually pretty well defined. The actual lethality assessment, all the front end of 988 is well defined. And then really the magic of it is to build out a system within 988 where people with lived experience, any amount of engagement that someone might need for as long as they want can happen when they're on 988. So that we immediately address the lethal means, but then someone can stay on the phone for like 5 hours if they want. I mean, who really cares? And what we've done is we've built this out. 95% of the calls we get are resolved within our 988 system. Let me put that in real numbers in Sacramento County in December of 2024. 1,290 people called 988 in Sacramento County. We resolved 95% of all those calls. 80 of those calls, we worked with our partnership with Sac County and the Community Wellness and Response team and provided a dispatch for which they went out and responded to that mental health crisis call. 4 of those calls total to us and to the county involved law enforcement. So when you do it right, when you have the partnership, when you work on it for years like we have, it works. Going upstream, every office for the Assembly and Senate at the Capitol and in their districts, we've trained on how to do a warm transfer into 988. So we've built a concierge line for all our legislators so that the district staff and the Capitol staff can deal with the amount of distress that people are calling in with. And that happened, during COVID. Jodi, we were part of establishing a 988 response in emergency rooms. Every emergency room in this region, anywhere we work, if someone comes in with an injury secondary to a suicide attempt, they leave with us calling them, and we call them every day for 30 days. If anyone comes to one of my health centers, and we serve 140,000 people in our region through our FQHCs, if they come up positive on the PHQ-9 for having been suicidal, they get a call. We don't wait for them to call. We call them. And so there is this sort of responsiveness that we need to build in to the system. But then there's also the need, not just on the front end with a place to call, but again, that person to respond, a culturally competent mobile crisis system, and a place to go, like a crisis receiving site. We've seen this amazing investment, BCHIP, the bond has funds, and I think a lot of people are applying to build out crisis receiving centers. Mobile crisis, we're seeing BH Connect is gonna help us more with that. I can't emphasize enough how much we need to adopt certified community behavioral health clinics in California. There are 12 of us in the state, 2 of us are actually accredited by the Joint Commission. There's an 85% federal match for mobile crisis in a CCBHC. And this is not a waiver, this is a program that is being funded directly by the feds. And I think we've noticed there's some turbulence over there. Luckily, our therapists from New Jersey are out there helping with that. But the CCBHCs are actually being driven by Texas, a really blue state, right? Kentucky, another blue state. Kansas, Missouri, Oklahoma. These are the states that have adopted it. And they've gone to town. So we have these incredible innovations here in California, led by fabulous leadership. And we have these opportunities that I think we're actually leaving on the table. We have to implement a pilot with a CCBHC. We're ready and able. When my organization became an FQHC, we had 3,000 patients in 2009. When you're given a way of actually serving people, you can grow it, and we have 140,000. So I see the opportunity, I see the goodwill, I see the state designing things, I see a clear opportunity to get into the CCBHC pilot. And so I feel quite confident. I run a 988 for 32 counties. I mean, I feel some optimism. The conversations with law enforcement, the work with the LAMPSers, it's pretty incredible. There's a way to go. So I'm going to just give you my rough rating out of 10, 1 to 10. 1, crap. 10, awesome. You know, I think our suicide prevention system is a national lifeline. It's been going a long time. So nationally, I'd give that like a 7 out of 10. Because that system, and even with the burden of becoming 988 and tripling the calls from 1-800-273-8255, you know, we've taken that on. We're going somewhere. Our mobile crisis system across our 32 counties, I'd give it like a 3 out of 10. We have very responsive counties where there's an infrastructure and economies of scale, like Sacramento, where we've got a 24-hour system going out there. We've got other places that are really challenged. And the places to go, alternatives to EDs, you know, I would give that a 3 out of 10 as well. But I'm not saying that in a negative way. I'm just saying that's where we are. There's the opportunity. When a sheriff calls me and says, hey, we're trying to figure out our role now in the new 988 system, that is the opportunity. When the state rolls out BH Connect, when the state rolls out BCHIP, with massive billions of dollars of funding for infrastructure, that is the opportunity. And so I see the opportunity for us to raise it, but it's at a 3. That's kind of my rule of thumb right now.
I'll just be really quick, but what I would say is, like what we experienced in Sacramento, one of the major pieces of feedback that I get is the local EMS agency administrators, the local medical directors, when connecting to these alternate destinations, they didn't even know those resources were in the community, right? And trying to build this program, the state says, hey, we have this cool new program, maybe your ambulance patient offload times are high, and whatever the reason is that you might be exploring this program, when they go to build this program, they have to talk with local law enforcement. They have to talk with, you know, these resources in the community that they themselves didn't know existed. And the more that we connect and make those partnerships, I think ultimately is where we get that whole of person connected care. So I'll be quick on that, but I think that is such an opportunity, and we see it just now in Sacramento with your approval.
Yeah, the 12,000 visits to our crisis receiving site, which we call the crib, 4% we referred in an ambulance to a hospital. So these are people who came with law enforcement typically, who would have gone to a hospital, and 4% of them only. The other thing we did was we allowed people to actually refer themselves. So if someone thinks that they need a crisis receiving site, probably a good idea to let them have a crisis receiving site. And, you know, to what Arvind has said, we had people at first, because we didn't do that, we had people calling 911. They were standing outside our facility. And law enforcement would come, and they would say, can you please admit me to this site? And law enforcement would knock on the door, would open the door, and that's it. So I think being responsive and just saying yes is critical.
Great. Do we still have, oh, there we go, 10 minutes. Thank you. Perfect. So panelists, we know what works. Everyone is talking about what is effective in follow-up, what is effective in a crisis response. We know that infrastructure around 988 system, a mobile crisis response diverts, you know, many of the folks that are calling in, both at the student level in the schools and in our communities. I'm hearing some great work that's happening in counties around a student mobile crisis response from some of our county partners. So how do we use the chassis that we now know that is working and build upwards from there? How do we scale this? And I'm going to start with you, Dr. Moulin.
Scale. So just because you've given me my 5 minutes, from where I sit with the behavioral health is we need more options for people to get outpatient treatment. Low barrier outpatient treatment, more walk-in options so that people can avoid the crisis. In that moment when a patient or a family member wants treatment, we need to have more urgent care type low barrier walk-in treatment options, particularly for addiction, like opioid use disorder. outpatient treatment, medications, like why is it so hard to get into outpatient treatment? Why is it so hard to get a prescription for Suboxone or buprenorphine, which is life-saving? Why is it so hard to get treatment for alcohol use disorder, stimulant use disorder? So low barrier, outpatient, walk-in treatment where people can get treatment on demand. Integrating that into primary care, our community health clinics, integrating addiction treatment, mental health treatment in a way that is low barrier, integrated, patient-centered.
I mean, I hesitate to say it, but I also think with these options, which I full and wholeheartedly agree with, and I think for us thinking about alternate destination or meeting people in their homes, but then also, right, I think the opportunity to scale comes in the sustainability of it, the fiscal sustainability of it. And so I think that has to be an opportunity that we look at. If we can meet someone where they are with a public EMS member who has a specialized training, I mean, these are something that your local tax dollars are already going to, right? Like this is already funded in there, so how do we leverage and create this fiscal sustainability? I mean, I think that is the opportunity that drives it forward.
Well, sustainability, I think on average, members of our California population send $2,000 or $3,000 more than other states to the Fed every year in taxes. The Fed has a thing called a Certified Community Behavioral Health Clinic. Getting some of that money back, 85% match on mobile crisis. We have to do this. We have to do this. We are attending calls, and we don't want people to die. I've been looking at this my whole life, literally. And we have an opportunity here. And we do have incredible other programs to work in with.
It's more Ken Zimmerman's, but that's a bad joke at this point. Honestly, it's more clubhouses and more, again, voluntary options that see people for people, and above all, expanding the reach of accountability based on the outcomes that folks like myself report, because we're going through the crisis, right? And just ensuring that someone has access post-hospitalization to these critical, life-changing, basic resources. And above all, ensuring that they have a pathway to re-enter community and be just like everybody else.
One last thing that I've sort of admired is that the state of Arizona, again, not a place I'd think of as really awesome when it comes to behavioral healthcare, having worked there as well. But in Arizona, regardless of your status, commercial coverage, insurance, Medicaid, the access system, uninsured, whatever, every single person who walks into a crisis site gets 1 day of free crisis care. The state pays through their access system and for anyone to get 1 day of crisis. And when I think of that 1 day of crisis, if it has what Dr. Moulin is describing, what I'm describing, what we're talking about, if that 1 day of crisis has just people with lived experience, it diverts people out of potentially a lifelong of multiple crises. So that is a very simple thing for us to look at.
All right, well, we're about in our last 5 minutes. I want to see if there's any final parting words from our panelists, things that we didn't get to that you all want to speak to. I also want to thank Arvind and others in the room who have self-identified as peers that have been carrying the torch for this work for very, very long, and continue to lead the way in what is needed for us to change the way that our systems and service delivery systems are serving people that are struggling with behavioral health challenges. Any other final words from our panelists? Can we take the question?
Hi, my name is Allison Monroe. I'm a family's advocate for the seriously mentally ill. Thank you. I'm concerned that reducing hospitalization is not the optimum goal. It's not the big goal. For me and the family members I know, it's keeping our family members alive and well and with a chance at recovery. You can go about reducing hospitalization the wrong way. It's being done right now in the county of Sacramento and in the city of Fremont. You cannot, if you have a family member who's in trouble and you call the police, they will not come unless a crime or violence is being committed. And that's a problem because some people need hospitalization even though they are not at that moment violent or criminals. What happens is that they will have to become, our family members, violent or criminals before they have a chance at hospitalization. And we especially want that early in the progress of a disease like schizophrenia. And expanding voluntary programs will not help them because they will not have the idea that their problem is illness and they need to get help for it. We need to preserve and expand the chance of hospitalization for our family members. I don't know if you would agree with that.
Yeah, I would agree with this in some way. Like, there are people who need to be hospitalized, so I hear you on this one. And then for inpatient, particularly for substance use, doesn't really exist. And so, yeah, you know, we're both want to be able to kind of get someone, one, you prevent the crisis, someone calls you back, and then when a person needs hospitalization, I think really the key is that that piece is easy, smooth, and that hospitalization meets their needs.
And I really appreciate that. And I'm not, in any way crapping on hospitalizations. God knows that they've helped me in really difficult times in my life, when once done correctly. And at the end of the day, hospitalizations are just one part of the plan. I think overall we all agree that people should have more paths and doors to getting care. And ideally, it should be defined on their terms because it's their life to live. How can we best support people who are struggling, even if they might not recognize it at that moment in time, that, hey, you actually, your life is meaningful. You do have a path to living. You do have a path to independence and recovery and a life of thriving. We should expand those doors to getting treatment and not judge people for them. Because if anything, it's that judgment, it's that stigma that prevents people from wanting to get care in the first place.
I wanted to say one other thing, and if we want to prevent homelessness, right, we need to support the families who are taking care of people, like at a minimum, right? Like, if you have a family member who's struggling, we need to support that family member and that family who can continue to support that individual. And that is one of the huge ways that we need to address homelessness, is by supporting the family to keep people in their homes. So thank you for everything that you are doing.
And not tell the family to get a restraining order.
I think, 36 years of my brother David having schizophrenia lets me know that we probably see eye to eye on some stuff. And it's the fear. It's the fear. And my experience is that I've had 36 years of not having the right system, which means that I've relied on hospitals. And, I think my dream is of the right system. And I know we have that leadership. We have the leadership here. We have the leadership of the state that sees that. And we cling to these existing systems because that's all we've had. And we're so frightened. And it's time for us to build out those systems simultaneously to reducing the other ones. And what we're dealing with now is law enforcement suddenly saying, no, not doing that anymore. It's a little premature, right? If we're going to have a system, an alternative, let's at least have it before we pull out, right?
Thank you. All right, I want to thank you to all of our all of our panelists for being here. Thank you all for everything that you do in this space, and for ensuring that that our hospitals aren't the only door. Look forward to seeing where the rest of the day goes to support efforts around this. So thank you all. Appreciate it.